Dear guests, dear President of Slovenian Academy of Science, dear guests from Academy of Science from Belgrade, there's also a guest coming from Academy of Science of Croatia from Zagreb, but he got stuck on the border, but he will be here on time. So dear colleagues, academicians, and of course dear friends, dear colleagues, physicians, it's a special privilege for me to open the symposium on hot clinical topics in heart failure, which is dedicated to the new book, which you can see, the book, the ESC textbook of heart failure. This is a very important topic. It's growing epidemics of heart failure, and this book will definitely help young physicians, physicians in training, as well as us, which are a little bit older and maybe on the other field of cardiology, to really to improve our work, our practice with patients. So we'll have a very interesting symposium. We'll touch different topics. One will be related to the diabetology in cardiology. We'll talk about also hemodynamic support in heart failure, the most severe form of heart failure, cardiogenic shock. We'll touch also heart transplantation, and of course all the relevant issues related to the really very important topic of chronic heart failure. So without further ado, I would like to invite our President of Slovenian Society of Science and Arts, Professor Peter Štih, for opening address. Thank you so much again for joining us.
Dear ladies and gentlemen, esteemed guests, dear colleagues, I was asked to have my address in English, but I believe that we will understand us if I switch in Slovenian language. As president, this is maybe a little bit easier for me to address you in this hall in Slovenian language. Torej, spoštovane gospe in gospodje, dragi gostje, veseli me, da vas lahko uvodoma pozdravim na Slovenski akademiji znanosti in umetnosti ob predstavitvi sodobnih spoznanj o srčnem popuščanju, s katerim je povezana tudi, kot je bilo rečeno, že predstavitev učbenika o srčnem popuščanju, ki ga je izdala Evropsko društvo za kardiologijo, Združenje za kardiologijo. In na njihovi spletni strani, kot sem pogledal, je knjiga napovedana kot, citiram, a must read for cardiovascular healthcare specialists. Tako da seveda verjamem, da je to pomembna pridobitev za vas. Čeprav seveda samo o tej temi kot zgodovinar ne moram povedati prav nič, kar bi bilo za vas lahko relevantno, pa imam vendar občutek, da se v modernih družbah za vedno starejšo populacijo vedno bolj soočamo s popuščanjem, s problemom srčnega popuščanja, ki je zato še kako relevantna, ne samo zdravstvena, ampak tudi znanstveno-medicinska tema. Ob tem ugibanju seveda pa nedvomno vem, da premika moderna medicinska znanost marsikatero mejo in da so bili tudi na področju obravnavanja in zdravljenja srčnega popuščanja narejeni številni novi koraki in doseženi marsikateri uspehi pri premagovanju te bolezni. Zato me še posebej veseli, da boste o teh stvareh danes razpravljeni na Slovenski akademiji znanosti in umetnosti. In nič manj me veseli, da je današnji dogodek organiziran v sodelovanju razreda za medicinske vede naše akademije skupaj s kolegi iz Hrvaške in Srbske akademije znanosti in umetnosti, kot tudi Združenjem kardiologov Slovenije. Vsekakor gre pri takšni obliki sodelovanja za dobro prakso, za katero bi si želel, da se nadaljuje tudi v prihodnosti. Na Slovenski akademiji znanosti in umetnosti si takega sodelovanja v takšnih formatih vsekakor želimo še naprej in ga tudi podpiramo. Spoštovane gospe in gospodje, naj se za konec samo še zahvalim organizatorjem današnjega dogodka, vsem skupaj pa da vam zaželim uspešno popoldne. In hkrati s to željo se moram vam tudi opravičiti, da se zaradi drugih obveznosti vas bom moral po koncu teh pozdravnih besed oziroma nagovorov zapustiti. Hvala lepa.
Since Professor Fras is not here, it's my special honor now to introduce academician Peter Seferovic from Belgrade, a member of Serbian Academy of Science, and as you can see, the first author of this book on heart failure. And it's amazing, we just talked and he mentioned about the book that he was dealing with, I think, 20,000 emails. 22,000 emails during the period of 3 years. 3.5 years. So you can imagine, the amount of work which is put in this book. And therefore, it's really a special privilege for me to introduce Peter and his talk on magic jump from diabetology to cardiology. This is a really hot topic during the last year. And he will specially discuss SGLT2 inhibitors and GLP-1 receptor agonists. So Peter, the floor is yours.
Thank you very much. It is my great pleasure to be here. Dear President of the Slovenian Academy of Sciences and Arts, dear Slovenian colleagues, how I start the projection here? Okay, we need first to show a small video.
The ESC textbook on heart failure is a mega project of the Heart Failure Association of the ESC in the last 3 years. The textbook was edited by 6 editors, and it is the result of scientific cooperation among 283 top heart failure experts around the world. It is published by the Oxford University Press, and 86 specially designed artistic illustrations were produced by the digital art studio team from Belgrade. The textbook was completed during the 3.5-year-long journey, which was exhausting but fun, involving a dynamic interchange with the authors. The textbook offers a well-structured, contemporary, and comprehensive framework for learning, and provides accurate, reliable, and easy-to-read information on complex subjects. The textbook provides a unifying educational material for all interested parties, including the ESC and HFA members of the Heart Failure National Societies, HFA Young, as well as the global heart failure community. The textbook represents the backbone of the HFA educational platform, making the clinical facts in heart failure accessible to everyone. By improving the HFA professional landscape and being the primary source of clinical knowledge in heart failure, the textbook influences all aspects of the HFA activities. The textbook provides state-of-the-art on the latest advancements in the management of heart failure, including fundamental, disease-modifying medical therapies in acute and chronic heart failure, with practical tips and expert advices on clinical implementation. It also delves into the advances in the management of comorbidities, devices, interventions, and new technologies aimed to improve patient care. Considering the rapidly evolving knowledge, the textbook will be regularly updated to provide new scientific data and to align its content with new ESC guidelines and position statements. The future of the textbook is bright, because it will keep evolving into the Smart Heart Failure textbook by implementing various technological advancements.
To the Slovenian colleagues, especially Mitja Lenščak, who put a lot of effort to organizing this meeting. everybody say the books are dead. And everybody I met would like me to give him one copy of the book. Because everybody would like to have something which is state of the art, something which something which will give him the profile of any of the topics which are in the book, which are up to date and digested and ready for preparation of the lecture, or just increase the knowledge he has. Everything which is up to date in heart failure those days is in this book. It is important to understand that we are very happy to learn that they are right now the activity to translate ESE textbook on heart failure in two important languages. One is Chinese and another one is French. So there are 11 different ESE textbooks, but none of them is translated to Chinese so far. This session is intended to show you some of the hot topics in heart failure. And as you may know, heart failure is one of the major problems worldwide. What you see here is the 4-pillar treatment in heart failure when SGLT2 inhibitors are recommended for the patient with heart failure and reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death with a class of evidence 1, level of evidence A. The major importance of SGLT2 inhibitors is that they prevent heart failure hospitalization in both primary and secondary setting, as well as in the patient with diabetes, chronic kidney disease, but also in heart failure itself. So the very vast majority of the patients with heart failure and comorbidities can use this drug. As co-editor of European Heart Journal, I'm dealing almost every month with some of the SGLT2 inhibitors articles, and as you can see, Javed Butler article is showing that SGLT2 inhibitors, in this case empagliflozin, is something which can be given to all heart failure patients with ejection fraction from less than 25 to less than 65. And we could not say that for too many of the drugs we are using. Emperor Reduce was the first study which showed clearly that empagliflozin or SGLT2 inhibitors are reducing the heart failure hospitalization and cardiovascular death. Dapagliflozin subsequently also showed a significant reduction of the risk of cardiovascular death and worsening heart failure in patients with HFrEF. Please notice that the important start of the activity of these drugs is very early. For DAPA, 28 days, for EMPA, 18 days. So it's something which gives us the possibility to administer the drug very early and preclude the complication and the progress of heart failure. But not only this, SGLT2 inhibitors were the first drug which were shown to have an excellent effect on the heart failure with preserved ejection fraction, reducing the composite endpoint of cardiovascular death and heart failure hospitalization. So that was true for empagliflozin, but also for dapagliflozin, with a relative risk reduction of 18%. So these drugs came from endocrinology, but now they are hardcore drugs which we're using in cardiology heart failure. Therefore, in this meta-analysis of comprehensive 5 randomized controlled trials, we can say that SGLT2 inhibitors are the drug of choice of this patient, not only regarding the effect, but also regarding the side effects. EMPALS study clearly showed that SGLT2 inhibitors are very favorable in patients with acute heart failure, and therefore we have the whole spectrum of heart failure covered by these drugs. As I pointed out, safety is excellent. Side effects are mild and can be significantly and clearly not only reduced but also healed very fast. The game is still on, and you can see the AMI trial from 2022 in December, which shows that EMPA will be very positive in patient after acute MI, providing a significantly NT-proBNP reduction and giving us the possibility to administer this drug not only in the patient with chronic heart failure but also acute myocardial infarction. So it is something which is coming to the both European guidelines on the left side and American guidelines on the right side, and this is probably one of the first possibility that the guidelines are completely in agreement. However, the new approaches which are practically put forward by 2023 guidelines are giving us the possibility to use accelerated and personal therapy in patients with HFrEF, and this is one article from European Heart Journal which is showing that this approach can prevent 14 deaths and 47 hospitalization in per 1,000 treated HFrEF patient over 12 months. This is amazing and has a high clinical significance. However, not all countries are the same, and you can see that the country with low and mid-income countries, showing in report age of study, are demonstrating that only 37% of the patients are getting the full anti-heart failure therapies, although all other patients has only the part of this important approach. When we look at 2023 focus update, we can see that patients with HFrEF and patients with HFpEF are clearly given heart failure SGLT2 inhibitors, in this case DAPA and empagliflozin, in order to reduce risk of heart failure, hospitalization, and cardiovascular death. So this is the first time that we have any drugs showing that it is important and can be given to the patient with an excellent long-term cardiovascular effect. Another drug, GLP-1 receptors, are extremely important. They came later in the last 5 years, giving us the idea that there is another drug from the field of glycoregulation, diabetology, which are getting to the field of heart failure, cardiology, with very good effect on the beta cells, with good effect also on the alpha cells, which are improving insulin secretion, insulin biosynthesis, and reducing apoptosis. As you can see, GLP-1 receptor antagonist has a positive effect on various organs, including heart, kidney, pancreas itself, skeletal muscle. So having all that taken together, it is clear that the multifaceted approach to the reducing cardiovascular death and heart failure hospitalization by GLP-1 receptor antagonist is very complex but is working. Interesting concept is novel dual incretin-based therapy. When we combine GLP-1 receptor agonist with GAP agonist, this double agonist is giving us the possibility to have much better and a much larger cardiovascular effect, but also effect on the glycoregulation, and it is used worldwide these days. GLP-1 and SGLT2 inhibitors went into the different guidelines very fast, and they are practically indicated in patient which does have or cardiovascular disease or heart failure or renal disease. And as you can see, ADA standard of care 2021 is recommending both GLP-1 receptor antagonist and twin creatine as the best way how we can preclude the further development of the and progression of heart failure. The same is true for the ESC AISD guidelines. And as you can see, in both drug-naive patient or the patient on metformin, SGLT2 inhibitors or GLP-1 receptor antagonists are used not only to treat patients but to prevent the disease in patients with very high cardiovascular risk. Recently, in the last 2 years, we had 2 big programs underlining the possibility that this drug, GLP-1 receptor antagonist, can be used in patients with HFpEF. And as you can see, HFpEF is one of the targets because we did not have any treatment so far. Instead, HFpEF study, which was addressing the obesity, we had a primary outcome of significantly improvement of symptoms and significantly weight loss, but also semaglutide was improving the secondary outcome with significant improvement in hierarchical clinical cause of reduction of the inflammation shown by reduction of the CRP, as well as significant improvement in 6-minute walking distance. That was true also with a part of this study addressing obesity and diabetes. The same results were obtained and significant improvement in symptoms and functional status, weight loss, but also 6-minute walking distance and CRP were shown. Last year, we had a chance to see the SELECT-HF, which was addressing the patient with HFpEF and HFrEF as well as unclassified patient. Semaglutide was compared with placebo, showing the event rate of MACE and heart failure composite was significantly reduced by semaglutide, not depending on the history of heart failure at enrollment. Also, all-cause mortality was significantly reduced, regardless of the type of heart failure, so they act on the HFrEF as well as on HFpEF. If we look at the safety was more or less acceptable, and having in mind the cost-benefit ratio, semaglutide was shown to be probably one of the drugs which will be in the future extremely important. Before I conclude my lecture, I would like kindly to let you know that in May 2025, 17 to 21, Belgrade will be again the venue for 2025 Heart Failure Congress. This is the big event. We hope this time it will have not 4,000 like Heart Failure 2012, but this time 7,000, having in mind that all what we are discussing and all what is in the ESC textbook will be extensively discussed in this meeting. I would like to thank you very much for your attention.
I thank Professor Seferovic for his excellent presentation. We'll ask questions at the end, and now it's my particular pleasure to announce next speaker, who actually doesn't need any introduction at all in Slovenia, because he has made many landmark contributions to cardiology at large and also the intensive care medicine. So the next speaker is Professor Marko Noč. He will talk about he will stay in his playground. He will talk about temporary hemodynamic support in cardiogenic shock. Marko.
Thank you so much, Mitya. So yeah, indeed, it's a great pleasure for me to be part of this symposium. And I'm going to switch now from the chronic heart failure to acute heart failure. And this is actually the topic of my entire, I would say, medical career. So in other words, I will touch cardiogenic shock, which is, the worst part of the heart failure, and this is why people die because of the heart failure, mostly. Of course, it's a very wide area, but I will focus on temporary mechanical circulatory support. In other words, on devices which can help to overcome this crisis of cardiogenic shock and by time to provide a definite treatment. Etiology of cardiogenic shock. Well, it's very straightforward. More than 70% of patients are in shock because of acute myocardial infarction, or in other words, acute coronary syndrome. And of course, in these patients, what really works is timely reperfusion of the occluded artery, timely PCI of the culprit artery. But I'm not going to touch this topic. I will focus on mechanical circulatory support in cardiogenic shock. So we have several devices, from very simple to very sophisticated. But of course, the first question we need to answer is, why are we doing that? Why do we think about hemodynamic support in cardiogenic shock? Well, when we do PCI, remember more than 70% of patients are acute MI, we want to improve hemodynamic stability of the patient before and during intervention. Because, we touch the coronaries, and of course this may further deteriorate patient situation, and this is the way how we stabilize the patient. Another reason is after we open the coronary artery, we want to buy time for the recovery of the stunned myocardium. In other words, part of myocardium is dead, unfortunately, and part of myocardium will regain the function. And we want to buy time for this myocardium to start to work. And the third reason is, if it doesn't help, if this is a terminal disease of the heart, we wanted to bridge patient to either artificial heart or heart transplant, which will be touched by academician Davor Milicic, who just arrived from Zagreb. Davor, thank you for coming, and thank you for making across the border on time. So, what are the current mechanical support devices for cardiogenic shock? These are like 5 candidates, from either simple balloon in aorta, which is just supporting the heart, to a catheter in the cavity of the left ventricle, which is like working same thing as the original heart, so to say. Then we have ECMO, extramembrane oxygenation, extracorporeal membrane oxygenation, where we take the venous blood from the organism, oxygenate it, and return back to the body. And then we also have devices like tandem heart and IVAC, which are somewhat modified to what I explained. And as I mentioned, there are different mechanisms of hemodynamic support with each of these devices, and different complications, and also in our territory and our countries, prices are also very important. And I will mainly focus on these 3 devices: intra-aortic balloon pump, Impella, and ECMO, which we are using also in our department. So first one, the most simple one, intra-aortic balloon pump. So this balloon is deflating and inflating in aorta, and thereby supporting the heart. And this is our experience. We started actually with these devices. Academician Mattia Horvath, my mentor and also founder of our department, actually started 1982. And then when we started our STEMI network program, the penetration of intra-aortic balloon significantly increased to between 100 and 140. These are the data till 2018, and nowadays then this number is already more than 3,000. So we have extensive experience with this device, and we believe it's helpful. But what about randomized trials? Well, if we take the most frequent form of shock related to the acute myocardial infarction, it has been shown some years ago that routine use of intra-aortic balloon only does not improve survival. These are the data for 1 year survival, you can see absolute overlap of the Kaplan-Meier curves with 4 patients with aortic balloon pump and 4 patients for conservative treatment only. But remember, we have also other causes of shock, other etiologies of shock. And this is more recent trial for the patient with acute on chronic cardiogenic shock. So these are the patients explained by academician Seferovic, who are in heart failure, and then something comes and they go to cardiogenic shock. And in these patients, there is evidence that intra-aortic balloon pump is probably beneficial as a bridge either to the heart transplant or ventricular assist device. What about veno-arterial extracorporeal membrane oxygenation in cardiogenic shock caused by acute coronary syndromes? This is a trial which was published some time ago, also in New England, and we were part of this trial. This was a German trial, and we were the only non-German center. And this trial showed that at 30 days, which was the primary endpoint of this trial, there was no benefit of ECMO versus standard treatment. There was another trial, a trial from Prague, from our colleagues from Czech Republic, and they tested VA ECMO, routine VA ECMO versus conservative first, and if it doesn't work, then you can add ECMO. And actually they added ECMO in conservative control group in 37%, and you can see there's no benefit of routine ECMO implantation. Routine, I emphasize the routine. What about the third device which I showed you, Impella? Impella, this is like a catheter in the left ventricle, which is pumping, in addition to the normal left ventricle, the blood from the heart to the aorta. It's just like putting another heart into the heart. And after many years, this was a first positive randomized trial in cardiogenic shock, clearly showing that patients with Impella do better, survive better than the standard therapy only. But, we have to be careful. These were only patients with cardiogenic shock caused by STEMI. So very, very selected group of cardiogenic shock patients. And as a consequence, only 30% of screened patients were actually included in the study. And importantly, other forms of acute coronary syndrome, non-STEMI, comatose survivors of out-of-hospital cardiac arrest, patients with RV failure, mechanical defects, they were all excluded. So if we apply that, we have to apply to the group of the patient which was studied in Danger shock randomized trial. And it's important that we are rational with this device, because the cost, as this in Slovenia, without the tax is 22,000. The cost of ECMO is 6,000. The cost of intra-aortic balloon pump is 1,000. And we all struggle with the cost limitations in medicine, and in particularly in patients with likelihood of dying between 40 to 50%. And these three devices may also be combined. And just showing you one patient from we did recently. So we started with VA ECMO. This was a patient with fulminant myocarditis, so not acute coronary syndrome. This was not enough. So we added intra-aortic balloon pump. You see the balloon inflated in the descending aorta in order to unload left ventricle, to help left ventricle while the patient was on ECMO. Unfortunately, this was not enough, so we replaced intra-aortic balloon pump with Impella. You see the Impella, so this is the cavity of the left ventricle. This is the Impella catheter. So blood is being sucked here and ejected above the aortic valve. So we ended up with so-called ECMELA configuration. And this patient actually survived because myocarditis, because we could sometimes somehow bridge that period of critical myocarditis till at least partial function of the left ventricle has been regained. And what is our philosophy? Because, whatever I tell you, it's always what matters is to show you what I do, because what you do, then you really believe in that. So we strongly believe that cardiogenic shock is not a yes or no phenomenon. And it's very useful. There's a classification of cardiogenic shock ranging from A, where there is still no shock but just a risk, to the extremis, where pretty much the patient is dying. And observed mortality in hospital mortality is very, very exponentially related to the stage of the cardiogenic shock. So it may be, and this is our philosophy, that one mechanical circulatory support device may not fit all patients. Just to illustrate you the heterogeneity of the patient with cardiogenic shock. So this is the patient, chronic patient with recurrent cardiac arrest, and actually we are implanting ECMO in this patient during chest compression because he was in cardiogenic shock and then he arrested, so you put him on ECMO. So for this patient, inhaler and intra-aortic balloon pump will not work, for sure. And then we have another patient which is quite stable after we put intra-aortic balloon pump, and you can see everything improved after we did the PCI and put the aortic balloon pump. In a couple of hours, the blood pressure was 120/60, heart rate was below 90. So definitely this patient would not need ECMO or Impella. So we can bridge him with a simple and cheaper device with less complication. And this is actually also the basis of our strategy. So if there is a beginning of cardiogenic shock, we go to the cath lab, obviously, open the culprit artery, and then put the balloon pump and monitor this patient very carefully. And if the patient improves, then of course we want it. We just go toward the weaning of intra-aortic balloon pump and take it out. If the patient is getting worse, so progression of cardiogenic shock, then it's very important aspect to answer the question whether this is reversible, that myocardium has some hope to recover, or if this is not reversible, if the patient is candidate for advanced heart failure, including LVAD and heart transplant. And if the answer is yes, then we either replace balloon pump with Impella or ECMO. And if this is not enough, we end up with ECMELA configuration, so putting together ECMO and Impella. If we have a crushing patient, which I showed you, we know that intra-aortic balloon pump will not work, so we mostly go to ECMO. Sometimes we can go also to Impella, and if needed, we switched again for another device and end up with ECMELA. So this is our algorithm. So it's a mixture of evidence-based medicine, mixture of local experience, and mixture of the fact what we can afford in our situation. So let me finish, dear colleagues, with my take-home messages. Very few, very simple. Integrate patient condition, age, comorbidities, level of hemodynamic deterioration, which I showed you. Of course, local expertise and availability of mechanical support devices when you make your decision what to do. We have to respect randomized controlled trials, which are actually the basis of evidence-based medicine, which is the state of the art nowadays. But remember that randomized trials should always be a tool rather than the rule in our decision making at the individual patient. And finally, very important, continuously analyze your data, outcomes, and compare them with leading international centers, because only these numbers, only these objective numbers will let you know if you are sailing into the right direction with mechanical circulatory support in cardiogenic shock. Thank you so much for your kind attention. And now it's a special honor to present my good friend, academician, Professor Dr. Davor Milicic from University Medical Center Rebro in Zagreb, also a member, as I said, of Croatian Academy of Science and Arts. So we are very happy today to have both representatives of Serbian and Croatian Academy of Science. And Davor will be discussing heart transplantation. If this is a still golden standard, Davor, I'm looking forward to hear your answer. Thank you so much for coming.
Thank you, Marko. I would like just to upload my presentation. Okay, thank you for this introduction, Marko, and thanks the organizers for the invitation of this interesting meeting. I can just greet you also on behalf of the Croatian Academy of Sciences and Arts as the Vice President of the Croatian Academy. And I'm very pleased to hold the lecture in this nice historical building in the center of Ljubljana. So I will share you some thoughts about heart transplantation. As Marko told at the beginning, is it still a gold standard? This is unfortunately a rhetorical question because it is. There is no better method for the advanced heart failure treatment than heart transplantation, despite of technological improvements in last 2 decades, I would say, despite genetic engineering, despite fantastic drugs, heart transplantation is here to remain and to be at the moment really the golden standard and the only curative method for the advanced heart failure, because if you have severely diseased heart, then you can cure that disease by replacing your sick heart with a healthy heart from a donor. So that is a very nice concept that still lives. This is how looks like the chapter on heart transplantation in Professor Seferovic's textbook on heart failure. I was honored to be a co-author together with Professor Mandeep Mehra from Harvard University and Professor Randy Starling, who is in charge for the advanced heart failure and heart transplantation at the Cleveland Clinic. So, what are the available therapies nowadays for patients with the advanced heart failure? To optimize guidelines-directed medical treatments and device therapy. This is just an option that actually doesn't fit criteria of the advanced heart failure, because if we have in front of us patient with advanced heart failure, that means patient is unfortunately refractory to conventional therapy, but sometimes we need to test him or her just to prove that concept. Then, of course, we have inotropes. We know that inotropes are, just switching off the fire, and it can't be for a long time that you have a patient on inotropes, despite the fact that there are some inotropes like levosimendan who can be administered to patient in certain periods, but that is a kind of palliation, not actually active treatment. Then we have some high-risk conventional surgery, from Batista operation that was a great disappointment to many other surgical correction methods to improve structure and function of the falling heart, but unsuccessfully. And then we have some interventions like mitra clip, TriClip, that are just a kind of bridge to, I would say, decision in patients that can be candidates for really advanced therapies. And among advanced therapies, we have two options. One option, Still golden standard is heart transplantation, and another option still emerging as a very attractive alternative, even for heart transplantation as a destination treatment, is mechanical circulatory support. We have heard from Professor Notch that there are many fruitful approaches of acute paracorporeal supporting the failing heart, including some intracorporeal devices like Impella, etc. But of course, they are temporary, and they serve as a bridge to candidacy, or bridge to decision, or bridge to durable implantable left ventricular assist device, or bridge to transplant. Rarely we have possibility that the patient recovers, and a good example is acute myocarditis, and then mechanical support could be bridged to recovery. And in these cases, it could be much better than transplantation, because such a patient with myocarditis that has a potential for recovery gets a greater benefit from temporary support rather than lifetime support, because his or her heart is going to recover, but this is a very small amount of population. Then we have total artificial heart, which is a different concept than ventricular assist device. Total artificial heart is still, I would say, a dream of cardiac surgeons, cardiologists, and engineers, despite the fact that there were few models of total artificial heart, and they were implanted in certain number of patients, but without spectacular results, and these results are uncomparable with the successfulness of left ventricular assist device concepts and heart transplantation, regarding complications and of course regarding survival. And then we have palliative care or hospice. This is a concept which could include, as I told you previously, some inotropes that could be periodically given. What we really need in that advanced heart failure field is to establish a better approach to patients that are candidates for palliative treatment, because in comparison with sophisticated heart transplant programs and MCS programs, in many countries this palliative care, which is important for a certain amount of patients, is neglected. So as I told you, heart transplantation remains the best option for the advanced heart failure, regarding two main goals of our treatment, regarding survival and regarding quality of life. Why regarding survival? Because nowadays we have cumulative 5 years survival that is approaching 80%, and 10 years survival which is about 60 or more %. And quality of life is also great, because about 80% of people have either very good, or that means excellent, or very good, or good quality of life years after heart transplantation. And that is much better than in patients with the durable mechanical left ventricular devices, despite the fact that in recent years, survival during the first several years is approximately the same in patients that receive heart transplantation and versus patients that are implanted with left ventricular assist devices. What are the frequent questions regarding the heart transplantation outcomes? Because what matters that are outcomes. What is the success rate? What percentage of transplants fail? What is the average life expectancy? Can transplanted patients fully recover? Which conditions influence the outcomes? And what are complications, disadvantages, and therapy side effects? And as Winston Churchill told once, regardless how beautiful the strategy is, you should occasionally watch the results. And here you can see surviving curves of patients after heart transplantation over decades, and it is clearly visible that survival rates are excellent and that they were improving through the time. And each experienced heart transplant center should be satisfied with these survival trends in heart transplantation, which are continuously improving. It is, you know, probably caused by accumulating experience and by some new immunosuppressants that are mitigating complications we can see in some of our heart transplant patients. And as I told you, the quality of life is also very good. Red is excellent, white is very good, green is good. You can see that more than 80% of patients, even 5 years after transplantation, have very, very good quality of life. And that is, besides survival, also of utmost importance when discussing heart transplantation versus other methods of the advanced heart failure treatment. What have we seen over time? That as there is a continuous lack of donor hearts, we are facing with sicker donors. We are less selective in picking some donor organs, and with sicker recipients. Population is growing older. We treat better and better coronary artery disease, myocardial infarction, chronic heart failure, but at a certain level, the cardiovascular continuum will close up with terminal heart failure, advanced heart failure, and these patients have a tendency to be older and sicker than a decade or few decades before. I would like just to underline that nowadays we see more than 50% of donor of recipient patients that already had prior cardiac surgery. Most of them are patients with implanted left ventricular assist device, and some patients had some other cardiosurgical operations, like patients with congenital heart diseases or valvular heart diseases. So there are many patients that have been already operated, and of course, therefore, the transplantation is technically more demanding than when we have primal operation. At least 40%, but we know nowadays even more, according to our experience, are patients that were supported with ventricular assist device until being transplanted. We have more sensitized patients than before, and that program of advanced heart failure treatment obviously becomes more and more complex due to complexity of our patients. What are the statistically significant risk factors for 1-year mortality? Very important ones. Recipient age, of course, then recipient GFR, then PVR, pulmonary vascular resistance, recipient's BMI, bilirubin, reactive antibodies, mean pulmonary artery pressure, donor age as well, ischemic time, which is also very important, and center volume in previous 3 years. Center volume is something very interesting, because here we can see that if you have less than about 60 transplants in 3 years, the mortality in these lower volume centers can rise up to 50% in comparison with experienced center. So it is very important to take that into consideration and to facilitate these potentially new centers to shorten that learning curve by helping them, because it could really mean increased mortality after heart transplantation. And here you see, because heart transplantation is not the method which is widely used in the world, unfortunately, there are about 60 or 61 centers which perform more than 20 heart transplantations per year. We in Croatia and New Slovenia are lucky, because we are always competing for the first place regarding heart transplant rates per million. In 2023, we were the champions in Europe with 12.4 transplants per million, and In previous years, Slovenia was taking the first place with about 10 to 11 heart transplants per million people. In comparison with some other countries, for instance, Great Britain, it's about 2.5 per million. Spain, 6.5. Austria is much better, 9. But we are above 10, and that is also very important to stress. What are the postoperative complications? Vasodilatory hypotension, acute allograft dysfunction, which sometimes can be cause of early post-transplant death, then right heart failure, that is relatively frequent complication, post-transplant renal failure, of course some rhythm disturbances, and sinus node dysfunction. Sinus node dysfunction we see much less until the bicable technique is state of the art in heart transplantation. More and more patients are bridged to being transplanted, and that number of patients bridged with mechanical circulatory support is increasing, but this is mostly because of increased implantation of left ventricular assist devices. Implantation of right ventricular assist devices, total artificial heart, or BIVAD is quite rare. Significantly, risk factors for one-year mortality. I would just underline previous MCS device, which increases mortality chance by almost 30%. ECMO, 70% higher post-transplant mortality if the patient was on ECMO. And if the patient was on a ventilator before being transplanted, that means almost double chance of mortality. Risk factors for 5 years mortality, they are different. As you can see, the most important are probably recipients' diabetes. It's more than 30% higher 5-year mortality. And of course, patients that were retransplanted versus patients which were primo-transplanted. Here are the graphs showing cumulative incidence of leading causes of death, and that is coronary artery vasculopathy, malignancy, multiple organ failure, acute rejection, infection, renal failure, lymphoma related to transplantation, and graft failure. Allograft rejection needs a permanent surveillance. This could be a major post-transplant complication, acute or chronic. Over the course of time, the risk decreases. There are combined immune rejection mechanisms, cellular, humoral, and most frequently mixed. Endomyocardial biopsy is still the golden standard for diagnosing rejection. And we have various protocols, each center regarding frequency of these biopsies. There are some methods, of course, of non-invasive surveillance, and we have also to monitor the patient with the question, does she or he develops cardiac allograft vasculopathy, which is quite a frequent complication and which is different from a typical coronary artery disease based on atherosclerosis. Here you can see the mechanisms which can lead to allograft vasculopathy. It can be a combination of immunologic and non-immunological mechanisms, particularly if you have a donor-transferred atherosclerosis, but over the time, of course, recipient can develop its own atherosclerosis, and these immune mechanisms can be really very silent, and you can have completely normal endomyocardial biopsies with the progression of coronary artery vasculopathy, which is also silent until the patient gets myocardial infarction or sudden cardiac death, or rarely signs and symptoms of angina pectoris, or the patient worsens the systolic function of the heart, implanted heart. Here you can see one of our typical patients with a typical progression of that cardiac allograft vasculopathy, which could be really severe, as you can see after year 4. And its treatment is very complex. Usually these vessels are so tiny that are not prone to be treated with classical stenting. We use drug-eluting balloons usually, and sometimes we even think of retransplantation. We have 2 of our patients that were retransplanted because that coronary arterial vasculopathy was so diffuse and so severe that that was the only way how to save their lives. Here we can see risk factors for development of coronary vasculopathy within 5 years, conditional on survival to transplant discharge. And you can see donor cause of death, cerebrovascular outcome versus head trauma is also important in a while. Then ischemic cardiomyopathy versus non-ischemic cardiomyopathy, from which suffered the patient before being transplanted, is also something that can influence the outcomes. But it's better to have non-ischemic than ischemic cardiomyopathy pre-transplantation, and of course retransplantation increases mortality. Infections, important cause of morbidity and mortality. We have cautiously to select the donor regarding exclusion, some potentially serious infections, and of course we have to monitor our patients during the entire post-transplant period to treat on time either early infections or opportunistic infections that we usually see during the first post-transplant year, or later community-acquired, but also opportunistic in some patients. Recipient's medical condition may affect outcome, such as age, sex, sensitization, pre-transplant cardiac disease, renal function, hypertension, smoking, diabetes, osteoporosis, malignancies, dyslipidemia. I told you that we face sicker and sicker recipients, and of course it could negatively influence our post-transplant results sometimes. The most important comorbidities that can adversely influence the outcomes are hypertension, dyslipidemia. All the transplanted patients should be on statins regardless of dyslipidemia. Hyperglycemia, diabetes appears in up to 1/3 of post-transplant patients. Osteoporosis can be a big problem, and last but not least, malignancies that are considered as the second most common cause of death after transplantation. I won't bother with these data about malignancies. I would just say that sometimes switching to mTOR inhibitors, for instance, can decrease malignancy and decrease mortality, and reduce incidence of malignancies has been observed in patients converted to sirolimus with complete calcineurin inhibitor withdrawal. So to conclude, heart transplantation remains the best treatment for the advanced heart failure. Median survival is about at least 20.5 years. Majority of patients have excellent or very good or good quality of life. There are some outcomes predictors that are important. We have to manage these patients comprehensively. We require their compliance, which is also very important. And we share, the whole humanity shares a big problems of not enough donor hearts for patients that could be saved by heart transplantation. So low transplant rates require alternatives such as MCS program, and in the future potentially total artificial heart, which could be maybe a real alternative for heart transplantation. And just for the very last minute of my lecture, here is the European population, about 750 million, heart failure 15 million populations if the prevalence is at least 2%. And then we can calculate how many the advanced heart failure as potential candidates for advanced therapies, including heart transplantation, are in Europe, and this calculation, extrapolating it from the American calculation for American population, is that in Europe we have about 100 to 200,000 people that are in a need for advanced therapies for the terminal phase of heart failure. And here are transplant numbers in the world. They don't exceed 600, just 600. Yellow is Europe, green is North America, and these red little bars are the rest of the world. So there is a high inequality in the chance for being transplanted, for being cured if you suffer from advanced heart failure, and the place where you live matters immensely in giving you chance for transplantation or chance not at all. Thank you very much for your attention.
Thank you, Davor, for comprehensive overview of the topic and for answering the question whether this is the optimal treatment. You convinced us with the data very, very obviously. And now I would like to move to our further presentation. This will be provided by Professor Mitja Lajnšak, Heart Failure Association Project and Relevance in the Region. Let me mention that Mitja really was, he's guilty for this meeting because that was his idea. And so Mitja, thank you so much for the idea. Thank you so much for the organization. Also, thank you so much for the organization by academician Professor Batellino, who also helped us. And now, Mitja, it's your turn to present us your views on the topic.
Thank you, Mark, for the kind introduction. I'll just pull up my slides. This is the one. It's my particular pleasure to be part of such a distinguished faculty, and I'll try to maintain the high level of previous presentations. I will not dive deep into the hard sciences much as my colleagues did. I'll try to translate whatever is available to the population at large. So to see how capable are we in doing what we should do. Now, the Heart Failure Association is the most important heart failure scientific society in the world. It organizes the most important congress next year in Belgrade. It publishes the most important journal. It publishes best guidelines. So we really can be proud of what we are doing in Europe. There is a specially dedicated website for the Heart Failure Association. Now, to know what we did in the region and also under umbrella of Heart Failure Association, we need to go back like 13, 14 years. In most of the projects, there will be always one name popping up, and that is Professor Seferovic, because he really gave momentum to many things in the Heart Failure Association. And this is the first one. So he started the National Heart Failure Society Summit. What does it mean? That summit gathers the Heart Failure Society presidents from the Heart Failure Association, and there is the growing number of presidents attending. Now we are about at the number of 40, which is very respectable number. So 40 presidents come to see how they can help, how they can maintain or even improve the standards of heart failure care in their countries. So the first summit organized in Belgrade, obviously, in 2011, but we also contributed to that. Slovenia and also Croatia, Davor organized a summit in 2019, I think, in Dubrovnik. We did it in 2015 in Ljubljana, and I'm proud to say that actually in Ljubljana The only international declaration of the Heart Failure Association was signed, and this is now on display in the European Heart House in the lobby. This is the only declaration that is on display in the European Heart House. So also Slovenia contributed significantly to that, along with the colleagues from Croatia and Serbia, obviously. The next project that I believe is very important is the Heart Failure Awareness Days that now is Heart Failure Awareness Week. The issue is that awareness about heart failure, also among healthcare workers and even more so among lay public, is low. And if people are not aware about something, they don't care about that particular problem. So the Heart Failure Association launched the Heart Failure Awareness Days to improve awareness about heart failure. Slovenia did many things. We involved most, if not all, the hospitals. I'll show you in the end how this works. And in 2015, we started to promote that during the Tek Trojk. You all know Tek Trojk. There was a team wearing T-shirts with logo of heart failure, so to contribute to awareness among lay population. So we won the award in 2015, and then after that 3 more times. I still don't have the results for 2024, but I'm quite optimistic. That will put us alongside with Germans and Italians who won the prize also for 5 times. We involve, as I said, most, if not all, then most hospitals, and we are always visible because we equip all the contributing healthcare workers with the same T-shirt, and that always happens in the same time. That is beginning of May, and individual hospitals do whatever they feel it's most important to increase awareness about heart failure. But we need to remember that we are doing that for the patients. Okay, also for ourselves, that we try to improve the standards, but the patients are in the center. There is one very important product of the Heart Failure Association, which is called Heart Failure Matters. That is the website that is for the patients. That was also launched in 2010, and it is the most visited website of the European Society of Cardiology. So that is the website with the most clicks. And it is the patient website. It's not scientific website. It's for the patients. Now, I said it started in 2010. Like other actions, Slovenia was involved from the very beginning, and we have been struggling to have the Heart Failure Matters in Slovene language. And you need to know that Slovenia has 2 million inhabitants, and that English or Spanish or Italian are spoken by many more people in the world. But now the odds are good. I believe that we will be able to launch the Slovenian website, I hope in next year. Negotiations still ongoing, funds secured. It's like 20,000 for initiation and then for yearly maintenance. But I'm quite optimistic that Slovenian website will be launched next year. When we have the patients in the center stage, we also need to know what is the epidemiology. The epidemiology is something we don't like, but I think it's key to understanding of the size of the problem. And Heart Failure Association launched the registries, which are trying to pick up the clinical practice. That started in year 2000 to 2001, and that was actually my beginning of heart failure and inclusion into Heart Failure Association. Since then, there were 5 registries, and now the 6th one is starting, and Slovenia was contributing to all of them. We were also leading the secondary analysis from 3 registries, so contributing with the patients and also with the interpretation of the data accumulated. In the last survey, we contributed like 1% of the patients in 2 centers. And that was also one of the reasons for next very important initiative. I mentioned epidemiology is important. But the problem is that across the world, we don't use the same methodology, and we don't collect the data in the same time frame. And one of the rationales of the Atlas initiative, to show how what is the epidemiology of heart failure and how the patients are treated, what is the capacity of every country, is to compare the data across the countries and to try to improve the epidemiological information. That again led by Professor Seferovic. So the first atlas was published, and we obtained interesting data. That is actually the first comparison in Europe and wider to tell us where are the main differences. The paper published 3 years ago. The second edition, now ongoing, maybe in the discussion Professor Seferovic will share with us at which stage we are. And the all initiatives actually then also are enabling us into the next project. I don't know why the slides are not advancing. And that was the setup of quality indicators. Because if you are trying to analyze something, then you need to have the standards how to do it. And actually, Heart Failure Association, also following the Americans, pulled up the set of quality indicators that should be followed in clinical practice. So if the patient is fulfilling these quality indicators, then you are doing a good job. If not, then we should improve. That was the first edition of the quality indicators, and that is the second edition. Now the registries can be analyzed in that fashion, Atlas can be analyzed in that fashion. So this will then again bring us further in the quality assurance for our patients. And this should be delivered in next project that again, you see the same name, I'm sorry for that, but that is the fact that Professor Seferovic really launched many nice initiatives, is to try to set the standards of quality of care centers across Europe. For that, there are many difficulties linked to the healthcare organization in the individual country, but the idea is that we should have some levels of quality of care centers, in this case 3 levels: community, specialized and advanced, with particular criteria they need to fulfill to be able to qualify for that. And maybe in the future that will also be needed for the reimbursement, but that maybe is not so close because it depends on every individual country. Things ongoing, Slovenia also the candidate, and we need to deliver in that respect now. Something that should not be forgotten, so this event is also for our young colleagues, for the residents. We thought that presenting a book would not be complete without providing the free copy of the book for all residents, Slovenian residents in cardiology, which actually will be done. There are 50 residents, and for each of them there is 1 copy reserved. So also young community is, it was also mentioned by Professor Seferovic, is very important contributor to everything what we were talking, because somebody needs to do the work in the end. Also, we are also doing it, but we need to rely on younger colleagues. And actually, in Slovenia, the working group, how is it organized? You all know Slovenia is, when I am speaking to my colleagues abroad, I always say Slovenia is a compact country. I always avoid small country. It's a compact country with many advantages. We are not putting in the practice so much as I would like. So we have 14 hospitals that do acute admissions, and the heart failure working group is composed that from every hospital there is 1 senior member and 1 young member. And we should make use of this network of hospitals for many things, from epidemiological research and also international trials, because I don't think that there are many countries in the world that can perform nationally representative randomized trials. We are able to do it. Also Croatia could do it, also Serbia could do it. And maybe that is the opportunity we need somehow to approach in the future. Maybe this will change very shortly. I have one grant proposal with our research agency, and let's see. Maybe there will be something happening in the future. This was already mentioned, Heart Failure Congress in 25 in Belgrade next year. I deliberately put the Vienna Congress alongside because this was the Congress that was closest to us, and that was also the Congress I was scientific chairperson. At that Congress there were 80 plus delegates from Slovenia presenting 20 plus abstracts, and I put myself to a challenge to improve these numbers. I hope with some help by Professor Seferovic and his team for the next year in Belgrade. So I am already now inviting you to consider to go to Belgrade and to be active participant in Belgrade. And I think it is not too optimistic to say we should go above 100 and we should go above 30 presentations. I think that is doable, and with your help I'm sure we can achieve that. I'll stop here. I hope I could show you that Slovenia is also contributing to many aspects and initiatives by the Heart Failure Association, and if we join forces in the region, I think we can do even better. And I'm quite positive for the future. Thank you for your attention.
Thank you, Mitja. Very nice presentation, very nice plans. So now we are moving to the discussion part. So I would like to invite both academicians, Docent Marina Polovina, Mitja, to join the panel. And so we'll have 5-10 minutes discussion. That's the plan. Not only about the book, but about the whole stuff. Do we have enough chairs? I will be here, so I think it will be okay.
And we'll get the microphone from.
Yes, that would be nice if we have the microphone. So, you know, what I learned is, of course, we have epidemic of heart failure. We have drugs, we have tools to help. Oh, thank you so much. And we have the book to guide us through the heart failure. And my question to distinguished panelists, you know, will be very interesting one. Where do you see treatment and, you know, everything related to the chronic heart failure in 2040?
Before we go to this important question, I just would like to introduce once again Maria Polovina, who is here. And they say you are as good as many people you have to work with you. We have in University Medical Center the group of 14 people, and Maria is among the most important one. So before you have the answer to your question, I would like kindly to ask her to tell us how she sees this book from the eyes of the young heart failure specialist dealing with the toughest, even what you mentioned in your lecture, cases of heart failure in your everyday practice.
Thank you very much, firstly, for the kind invitation to be here in this very important historic institution, and also to talk about this very important textbook of heart failure. It is the first of its kind in the history of European Society of Cardiology and European Society of Heart Failure. And to briefly answer your question, I think that, and that is what I try to teach my students and also to instill in my younger colleagues, you need good knowledge. You need well-structured understanding of the pathophysiology, of different etiologies of heart failure, and also need good knowledge of the treatment, of the management, of all the principles of medical and device management of heart failure, both acute and chronic, and of all the comorbidities. And then you also need to understand how evidence base is produced and how it is interpreted. And I believe that all of that can be found in this textbook in a user-friendly manner. And we now live in a digital world where most of our young colleagues are prone to want to have a digest of knowledge, something that can be just, clicked in their hands, which is difficult to achieve. But this textbook also has its or web-based copy, which is available with the hard copy. And there, whenever you need an answer to a particular question, to a particular clinical problem, you can find it simply by going to the web-based platform and, just putting keywords or just asking the problem. And yeah, I think it is very important for young colleagues and probably for improving our practice to instill the culture of learning and of being systematic. And thank you for your question, Professor.
Okay, so now, Tower, you start to answer my question. 2040, heart failure.
It is not an easy question to answer because medicine develops very, very rapidly, and I think in the next 20 years we can expect realistically to get at last appropriate total artificial heart, for instance. And that could be a way how to enable so many people all around the world to be saved from the death and suffering while they live with the advanced heart failure, which is a terrible, terrible state. Then, beside that, I see also in the future some new medications that are going to come. There are a lot of medications that are under investigation. Most of them disappoint us after being studied because of either side effects or less or ineffectivity. But as we can witness from the last 10 years, there is a really substantial improvement in treatment of chronic heart failure by introducing of SGLT2 inhibitors and some other medications, but particularly SGLT2 inhibitors, which really showed great potential for the patients with chronic heart failure, regardless, for the first time, regardless of ejection fraction. So I think in the near future we'll have some new medications, and we have to focus on morbidities that lead to heart failure as the final phase of myocardial disease. So I think with raising awareness of how important heart failure is as a diagnosis and what can we do in the course of its progression, we have to change our everyday practice by identifying more and more patients that are at substantial risk for developing heart failure, and to treat them on time. Because as you know, probably the American College of Cardiology classification is ABCD, classification of heart failure. A is risk factors without structural or functional impairment of the heart. So we'll have to focus on these patients, or B, patients that have structural or functional impairment but no symptoms and signs. These patients are curable, treatable, and they need our attention, and thus we will reduce probably the number of severely diseased heart failure patients, which is very important, because we tell nowadays that heart failure is the leading malignant disease in the world, because there is no malignant disease with the prevalence of at least 2% and with such a bad survival, because despite all our therapies, we have 50% mortality in 5 years since heart failure was diagnosed. So that is something really challenging for the future, to introduce new therapies, to improve our diagnostics, and to raise awareness that most of the patients that developed and that will develop advanced or severe, clinically severe heart failure should be treated on time, and thus we can prevent the progression of disease and death from heart failure and its consequences to the whole body.
So if you have any questions, comments from the audience, of course, welcome. Just raise up your hand and we'll bring you the microphone. And in between, I would like to ask Peter to share with us your view on 2040.
It's very difficult to say, because right now we are in the position to say that some of the heart failure drugs which are dramatically change the outcome of heart failure patient are on the board, and we are using them to the higher extent. SGLT2 inhibitors, as it was said, GLP-1 receptor antagonists, are very, very good, but they are not solving the problem. So I see that the major advantage should be in the prevention of the heart failure. Fighting with the comorbidities, we know that the comorbidities, the risk factors are the same for cardiovascular disease as well as for the heart failure. At the same time, we are witnessing today the increasing knowledge about HFpEF, and this is a big challenge. We know a lot about the treatment of heart failure with reduced ejection fraction. We knew less about the heart failure with preserved ejection fraction, but we know much better now. We have SGLT2 inhibitors. We probably will have soon some other drugs, but also we have some new knowledge that within the frame of what we call HFpEF are some cardiomyopathies. And these cardiomyopathies can be specifically treated with the drugs which are now on the board, like mevacaptan for hypertrophic cardiomyopathy. And there are two important points which are connected with artificial intelligence. And this is the making a diagnosis of some of these cardiomyopathies very early with genetic testing, as well as with the CMR. And the late gadolinium enhancement in this patient can provide us with some of the new and very important insight who within the frame of the mosaic of different HFpEF patient can be treated. The big problem remains the comorbidities. The major comorbidities, obviously, heart failure and diabetes. Diabetes is another epidemic which is in intersection with the heart failure and coronary artery disease. So treating all these patients, treating all these comorbidities will help us. We have iron deficiency, which is also very important, and obviously we have obesity, which rise right now as one of the important targets. However, ladies and gentlemen, let me say, for the more than 20 years, being first the president of the Heart Failure Association, then the vice president of the European Society of Cardiology, I understood one thing. And this is not only to have the drug in our hand, not only to know how to apply the drug, but also to have the power in all these countries to implement the drugs. So I've been in 37 countries this year, including some of the countries of the Central Asia, Southeastern Europe, and North Africa. And I may tell you that in most of these countries, let's say 60% of these countries, the implementation of everything we know today is insufficient and poor. So the humanity is facing a big challenge how to implement what we know, not mention the transplantation, not to mention the left ventricular assist device and the things like that. So it's not only the knowledge, it's also the implementation. And I'm really happy that in Western Balkans area, and when we go more and more around, we understand how good we are.
Well, Mitya, now we have, we heard total artificial heart, we heard very important point, new drugs, and in particular implementation, and of course, everybody emphasized prevention. So what is left for you?
Well, I would argue that a couple of things, but I agree that prevention is the key. We need to know that also due to aging of the population, more and more people come to the age when something will happen. And with better prevention of cardiovascular disease, and actually Slovenia is among the countries where mortality for cardiovascular disease is lower than cancer mortality, is lower, 10, 11 countries in the world for men. Denmark is the only country that has that for women and men. So that opens the window for other chronic diseases. So I believe that the epidemiology will change over time, and eventually more people will end up with heart failure, cancer, which are two leading causes of death. The prevalence of heart failure will increase. We performed the classical epidemiological study in Murska Sobota, where we screened the population, not the patients, population. And the conservative estimate from our data is the prevalence is 4.7% already now. So that means every 21st Slovene has heart failure now, and that is conservative. So then we need to help these people. I believe that more and more patients will be treated with devices, because device implementation is still low, because they will be more and more affordable, easier to implant, and more centers will do that properly. So we still need to pay attention that the sufficient number of devices are implanted. And what I also think will make big changes, artificial intelligence was mentioned for diagnosis, but then also for treatment implementation, because we need to know the randomized trials as they are performed now are measuring population effect, not individual effect. So with artificial intelligence and combination of genetic analysis and metabolomics, I think we'll pinpoint the patients that can have benefit of individual therapies, although the therapies did not have the population effect. So I think that will be the future, the individualized therapy, which in 15 years, I believe, will be much more affordable than today.
Okay. Thank you so much. I think we came to the end. So thank you so much to all panelists, to all presenters. Of course, thank you for this great book, Peter. And thank you for giving us opportunity to present this book to the Slovenian audience. And thank you, of course, you, ladies and gentlemen, for coming. And across the street, I think there is a drink and some snacks. So welcome, and thanks again for coming.